Be talking about inflammation. So inflammation. So when there is an offending agent, our body will respond. So that response of vascularized tissue. So the response of a vascularized tissue that delivers the WBC and the molecules of host defense. The molecules of host defense from the circulation to the site of infection and to the site of cell damage in order to eliminate the offending agent. So this is basically the inflammation. So when there is an injurious stimuli, our body will respond. So this response of the vascularized tissue that will deliver the WBC and the molecule of host defense from the circulation to the site of infection and cell damage in order to eliminate the offending agent. That response is called as inflammation. Although, even though the inflammation is suggesting a harmful reaction, it is actually a protective response that is essential for our survival. It actually serves to rid the host, actually the initial cause of cell injury. That is, it is eliminating the microbe, the toxins, and the consequence of such injuries. That is, the necrotic cells and tissues. Necrotic cells and tissues are getting eliminated, and the microbe and toxins, they are also getting eliminated. The mediators of the defense, it includes the phagocytic WBCs, then antibodies, complement proteins. So these will act as defense. Most of these normally circulate in a resting state in the blood, from where they can be rapidly recruited to any sites in the body. So some of the cells involved in inflammatory response also reside in tissues where they function as sentinel. So the process of inflammation, it deliver the circulating and cells and protein to the tissue and activate this recruited and even resident cells that are normally presented, as well as a soluble molecule which then will function to get rid of the harmful or the unwanted substances. So think, if there is no inflammation, this infection it would go unchecked. The wounds would never heal and the injured tissue might remain permanent festering sore. So when you are writing the suffix itis, it is actually indicating inflammation. For example, if there is inflammation in the appendix, it is called appendicitis. And if it is in conjunctiva, conjunctivitis. So this suffix is indicating inflammation. Now, what are the causes of inflammation? So, the causes of inflammation. The inflammatory reaction may be triggered by a variety of stimuli. So, one such stimuli is infection, that is, bacterial infection, viral infection, fungal infection, parasitic infections, and certain microbial toxins are among the most common and medically important cause of inflammation. So the different infectious pathogen elicit varied inflammatory responses. That is, from mild acute inflammation that causes little damage and successfully it can be we can eradicate that infection. In the other extreme, it is a severe systemic reaction that can be fatal to prolonged chronic reaction that causes extensive tissue injury. So the outcome are determined largely by the type of pathogen and the host response. So the second cause is tissue necrosis. So the tissue, if it is getting necrosis, it will elicit inflammation regardless of the cause of cell death. So cells may die because of ischemia, that is due to reduced blood flow, the cause of MI, or trauma, physical injuries, chemical injuries, thermal injury, as in burns or frostbite, irradiations, exposure to some environmental chemicals. So several molecules released from the necrotic cell are known to trigger inflammation. So this will be described later. So next is the foreign body. So foreign bodies such as dirts, sutures that we use in surgery, or the splinters, so they may elicit inflammation by themselves, or they cause sometimes they will cause traumatic tissue injuries, or sometimes they can carry microbes. Even the endogenous substances can be harmful if they get deposited in tissues. For example, actually the urate crystals in urate crystals in gout. Another example is the cholesterol crystal in atherosclerosis. Lipid in obesity associated metabolic syndrome. Obesity associated metabolic syndrome. So the fourth cause of inflammation is the immune reaction. Immune reaction. So this can also be called as hypersensitivity. So these are reactions in which the normal protective immune responses damage the individual's own tissue. So the injurious immune responses may be inappropriately directed against self antigen and it will cause autoimmune diseases, or maybe reaction against environmental substances, as you can see in allergies, or against the microbe. So inflammation, it is a major cause of tissue injury in these type of diseases. So because the stimuli for the inflammatory response, that is a self antigen or the environmental antigen, it cannot be eliminated, right? So autoimmune and allergic reactions tends to be persistent and it is actually difficult to cure. So they are often associated with a chronic inflammation and are important cause of morbidity and mortality. So basically we are having two type of inflammation, that is acute inflammation and chronic inflammation. So the acute inflammation, it is actually faster and shorter duration, whereas the chronic inflammation, it is slower and longer duration. So the main principal cells of acute inflammations are neutrophils. The principal cells of chronic inflammations are monocyte, macrophage, and lymphocyte. So in acute inflammation, the local signs and symptoms, they will be more prominent, but the tissue injury and the fibrosis, it will be comparatively less as compared to the chronic inflammation. So there are actually, what are the cardinal signs of inflammation? Cardinal signs of inflammation. So there are four cardinal signs of inflammation given by Celsus. They are rubor, Calor, Dolor, tumor. So rubor means at the site of inflammation there will be redness. So these are the four cardinal signs of acute inflammation. Acute inflammation. Calor means heat. Dolor means there will be pain and there will be swelling. So the fifth sign of acute inflammation, it was given by Virchow and it is called functio laesa, that is loss of function. So these are the cardinal signs of acute inflammation. Now the mechanism of acute inflammation. So what is the mechanism of acute inflammation? So this is actually the blood vessels. So if this is a blood vessels, and here we have the endothelium. So this is the basement membrane, and here we have the endothelial cells, and this is a blood vessels. So during normal blood flow, the leukocyte, so these are the leukocytes. These are the leukocytes. So in acute inflammation, this leukocyte has to cross the basement membrane. So they must cross the basement membrane in acute inflammation. Then only they will move towards the site of injury. So after moving towards the site of injury, these WBC will phagocytose. So the microbe will be killed. So in acute inflammation, in the acute inflammation, there are two events that we can discuss. That is a vascular event and cellular event. So the vascular event includes vasodilation, an increase in the vascular permeability, then so due to vasodilation and increase in vascular permeability, there will be stasis of blood, and so there will be margination. So in cellular events, that is what is happening to the WBC. So there will be rolling, adhesion, then transmigration, chemotaxis, and phagocytosis. Phagocytosis. So now these each events will be dealt in detail. Discussing about the vascular events, the earliest response is there will be early transient vasoconstriction. Then there will be vasodilation. So the earliest event in acute inflammation, it is vasodilation. Here arterioles, there is a dilatation of arterioles and it is mediated by histamines. So due to this vasodilation, there will be increased blood flow and there will be heat and redness at the region of vasodilation. So the next event is increased vascular permeability. So this is the most critical. So this is the most critical step or the vascular event in acute inflammation. So due to increase in vascular permeability, there will be the leakage of fluid to outside. So this forms the exudate. So it is very important to know what is the difference between exudate and transudate. So the exudate, the specific gravity. So the specific gravity will be greater than 1.02 and in transudate, the specific gravity it will be less than 1.02. Exudate is a inflammatory edema, whereas transudate is non-inflammatory edema. The specific gravity, it is greater than 1.02 because this will be rich in the proteins and cells, whereas the transudate will be poor in proteins and cells, and there will be high LDH, that is lactate dehydrogenase, whereas the transudate, it is having low amount of lactate dehydrogenase. So now discussing about the mechanism of increased vascular permeability. So what is the mechanism of increased vascular permeability? So these are our endothelial cells. So if these are the endothelial cells, so the endothelial cells, they will contract. So they will form like this. So the endothelial cells will contract and you can see that there is a gap. So the contraction of endothelial cells, this is the most common mechanism. And this is happening to a post-capillary venule. And the vascular permeability is increased due to histamine, then leukotrienes, bradykinin. So this is an immediate transient response, which is happening in the duration of 15 to 30 minutes. So the second mechanism is a mild endothelial injury. There is mild endothelial injury, for example, in case of burns. So due to this endothelial injury, the endothelial cells undergo apoptosis. So in this case, the leakage, it begins after 2 to 12 hours, and this will continue for several days. So in case of burns, in case of mild endothelial injury, what you can see is a delayed, prolonged leakage. So another mechanism is if there is severe endothelial injury. If there is severe endothelial injury, there will be the endothelial cells. It undergoes necrosis and detachment. So this in this case, the leakage, it actually starts immediately. So the leakage starts immediately and it actually continue for days. And this response is called, it will be immediate and sustained response. So this is immediate and sustained response. And there is increase in vascular permeability. So there is increase in vascular permeability and there is stasis, that is slowing of blood flow. Slowing of blood flow. So when the blood flow is slowed, there is a redistribution of WBC. There is redistribution of WBC towards margin. So this is called margination, or it can also be called as pavementing. So this is the vascular events that is happening. Now discussing about the cellular events. So I have discussed about the vascular events. By recapping, there is vasodilation and increase in vascular permeability, and I have discussed the three mechanisms of increase in vascular permeability. So the next important is the cellular events, and so the first step is rolling. So what is this rolling? Actually, there is increased expression of adhesion molecules. So there is increased expression of adhesion molecules, and these are actually mediated by selectins. So these are actually mediated by selectins. Actually, we have three types of selectins. That is E-selectin, because this molecule, it is expressed in endothelium. Then we have P-selectin. This molecule is expressed in platelet and endothelium. Then we have L-selectin. That means these are expressed in leukocytes. So if this is the blood vessels and these are the endothelial cells. So the endothelial cells, it will express a molecule which is called as E-selectin. This endothelial cells also express a molecule which is called as P-selectin. So in our blood, we have, suppose this is a WBC, that is leukocyte. So this leukocyte, it will express a molecule that is called as L-selectin. Now, here we are having, so this is a neutrophil. So this is a neutrophil, and that neutrophil, is having a glycoprotein. So this is Cellular Lewis X modified glycoprotein. Glycoprotein. So the complementary molecule, you can see that the complementary molecule for this E-selectin and the P-selectin is the Cellular Lewis X modified glycoprotein. So they will be binding for rolling to takes place. So the expression of selectins, this expression of selectins, that is L-selectin, E-selectin, P-selectin. So the expression of selectins, they are actually induced by the cytokines such as interleukin 1, tumor necrosis factor. Then we have interleukin 1. So here you can see there is P-selectin. Actually there is redistribution of P-selectin. That is, this is a endothelial cell. So in the endothelial cell, this is endothelial cell, and this is actually the Weibel pelade bodies. Weibel pelade bodies. So this is having P-selectin, and there is expression of this P-selectin by redistribution. And this is actually mediated by histamine and thrombin. Histamine and thrombin. So here I would like to discuss a clinical correlation, that is LAD2. This is leukocyte adhesion deficiency type 2. So what is this LAD2 deficiency? Actually the pathology is there is a defect in the Cellular Lewis X modified glycoprotein. X modified glycoprotein due to mutation in the genes. Actually there is autosomal, it is due to autosomal recessive disorder. So due to the defect in the Cellular Lewis X modified glycoprotein, there is defect in rolling and adhesion. So clinically the patient may present with increased risk of infection, because for the inflammation to happen, so these steps are required: rolling, adhesion. So if there is no inflammation, there is increased chance of infection. So next cellular event is adhesion. So adhesion means there is firm attachment between the WBCs and the neutrophil and the endothelial cells. So this is actually, adhesion is mediated by integrins. So integrins are of two type. So one is the beta 1 integrin and the other is beta 2 integrin. So this beta 1 integrin is otherwise called as VLA4 and the beta 2 integrin is otherwise called as CD11, CD11, CD18, LFA1 or MAC1. So these integrins, they are present in WBC. That is, they are present in the leukocytes. The receptors, that is VCAM1 and ICAM1. So this VCAM1 and ICAM1, they are actually present in the endothelial cells. So for adhesion to take place, it is mediated by integrins which are present in leukocytes, and the complementary must be present, that is the VCAM1 and ICAM1 that is present on the endothelium. The level of integrin, it is increased by interleukin 1 tumor necrosis factor. So one of the another clinical point which I would like to discuss here is LAD1, that is the leukocyte adhesion deficiency type 1. So this leukocyte adhesion deficiency type 1, so it is also an autosomal recessive disorder. So due to the defect in the genes, the pathology is there is a defect in synthesis of the CD18 molecule. So CD18 molecule. So this CD18 molecule, it is required for the synthesis of beta 2 integrin. It is required for the synthesis of beta 2 integrin. So the patient clinically present with, there will be recurrent infection because the step of inflammation, it is not happening. And one more feature is there will be delayed separation of the umbilical cord due to this defect. So the next cellular event is transmigration. Then chemotaxis will appear. So what is this transmigration? So it is the movement of the leukocytes across the endothelium and the basement membrane. So this transmigration, it can also be called as diapedesis. So this transmigration is called as diapedesis. So this transmigration, it is mediated by PCAM1 or the CD31. It is a marker which is represented in the PCAM1. Here the leukocyte, it actually secrete collagenase. So this will actually secrete collagenase, and this collagenase will go and destroy the basement membrane. So this is what is happening in transmigration. Now the chemotaxis. So what is this chemotaxis? It is the movement of the WBC in the direction of a chemical stimulus, of a chemical stimulus towards the site of injury, towards the site of injury. It is so the neutrophil has to reach at the site of injury. So there will be certain chemicals that will help in this chemotaxis. So what are the chemotactic factors? So the chemotactic factors, it include both endogenous and exogenous. So the endogenous include C5a, LTB4, interleukin 8, whereas the exogenous include the bacterial cell wall product, N-formyl methionine. Now, what is the mechanism behind this chemotaxis? So, actually, this ligand, so there is a ligand. So, if this is a ligand, and that ligand, it go and bind. So, it bind to a 7 transmembrane G protein coupled receptor on the surface of leukocyte. So if this is a WBC, so on the surface there is a 7 pass receptor. 3, 4. So there is a 7 pass receptor. This is a G protein coupled receptor, or a 7 pass transmembrane receptor. So when this ligand binds, there is actually the calcium level will be increased. Cytosolic calcium is increased. So due to increase in cytosolic calcium, there is polymerization of actin at leading edge. So there is polymerization of actin at leading edge, and there is actually movement of WBC, that is a leukocyte. And at last comes the phagocytosis. So in phagocytosis, there is actually the recognition and attachment. So for phagocytosis to happen, there must be a receptor. So if this is a so we have mannose receptor, then we have scavenger receptor, and we have receptors for opsonins. So these are receptor for opsonin. This is scavenger receptor, and we have got mannose receptor. So what is actually opsonization? So opsonization is if there is a microbe, that microbe we are actually coating, so that microbe is coated so that it can be easily phagocytosed by the phagocytic cell, so that it can be easily phagocytosed. So what are the opsonins? So the Fc fragment of IgG, then C3b fragment, and the serum proteins, in serum proteins like the fibrinogen, serum protein like fibrinogen, then we have a C reactive protein and mannose binding lectin, mannose binding lectin. So these act as opsonins. So if this is a macrophage and that is having pseudopores, so these are the pseudopores, and there are receptors here. Suppose if there is a microbe, so this is a microbe, so that microbe will be engulfed and this microbe will be made inside. So this is called the phagosome, and this cell contains a lysosome that is having certain granules, that is, so this is a that is having many certain enzymes. So this is a lysosome. So these two will fuse together to form a phagolysosome. So they will form a phagolysosome. So this is the formation of the phagolysosome. So after this, killing happens. That is, there are killing is by reactive nitrogen species. So there is reactive nitrogen species. So such as, so these reactive nitrogen species are microbicidal. That is, it will kill the microbes. Then the killing also takes place with the help of reactive oxygen species. So with the help of reactive oxygen species. So the oxygen will be converted into, so this oxygen will be converted into the superoxide free radical with the help of NADPH oxidase. This will form the hydrogen peroxide and chloride. So when hydrogen peroxide is formed, there is chloride, and with the help of myeloperoxidase, with the help of myeloperoxidase, these two will combine together to form HOCl, and this will kill the bacteria. So this will kill the bacteria. So this hydrogen peroxide halide. So this is most effective bacterial killing mechanism. Bacterial killing mechanism. So now what is the respiratory burst? So the oxygen dependent killing. So the respiratory burst or the oxidative burst. This is the oxygen dependent killing. That is a respiratory burst. There is something which is called as oxygen independent killing. That is mediated by enzymes present in lysosomes. Lysosomal enzymes such as the lactoferrin, bacterial permeability increasing protein, bacterial permeability increasing protein, then lysosome, lysozyme. So this phagocytosis, it was discovered by phagocytosis was discovered by Eli Mechnikov. He is the person who discovered phagocytosis. So there is something which is called as frustrated phagocytosis. So what is meant by this frustrated phagocytosis? So this occurs when cell encounters a material, but the characteristic of this material is that this cannot be easily phagocytosed. So this is frustrated phagocytosis. For example, the immune complex. So the immune complexes which are deposited on flat surface, deposited on flat surface like the glomerular basement membrane. So this is frustrated phagocytosis.